Hello and welcome everyone to tonight's webinar, the fourth in the series on cardiac care. This webinar covers a wide range of paediatric topics, including heart murmurs, congenital disorders, and infections and pericarditis. I am Dr. Leonie Harcourt, a GP education advisor at the Capital Health Network. Also with me tonight is Kunal Mohiti, the events lead at Capital Health Network, and of course, our expert speaker presenting from Sydney on Gadigal land, paediatric cardiologist Dr. David Youssef. The next cardiac webinar in the series will be on the 24th of September, and Dr. Mohammed Paymard will be presenting on cardiac arrhythmias in adults. So first, we would like to acknowledge the Ngunnawal people, the traditional custodians of the land we are meeting on. We acknowledge and respect their continuing culture and the contribution they make to the life of this city and this region. We also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. Housekeeping, as always, all participants or attendees have been muted, and please address any questions in the Q&A section of your Zoom window. And David has very kindly agreed to answer questions throughout his presentation and at the finish. And with regards to CPD, please feel free to report 1.5 hours of educational activities to your CPD home. Also a flag for the free resource Health Pathways, which has pages on paediatric heart murmurs and congenital heart disease. So over to Dr. David Youssef. We're very lucky to have him. And David is a paediatric cardiologist with a strong focus on pulmonary hypertension and advanced cardiac imaging. He completed his medical training at Griffith University and holds a Bachelor of Pharmacy from the University of Sydney. His clinical journey has taken him through major hospitals across Australia and internationally to the Stolly Children's Hospital in Canada, where he completed dual fellowships in paediatric echocardiography and 3D imaging, as well as paediatric pulmonary hypertension. David currently leads the Paediatric Pulmonary Hypertension Pilot Program in Sydney, integrating multidisciplinary care for complex patients, and has helped establish a dedicated bronchopulmonary dysplasia clinic for NICU graduates, so babies who've come out of NICU. And he works at the Sydney Children's Hospital Network and is actively involved in medical education, of which we're beneficiaries tonight, and research. And he's recently published in Frontiers and presented at leading international conferences. So we're very lucky to have him. Please join me in welcoming Dr. David Youssef. Thanks, David.
Thank you so much, Dr. Harwood, and Colonel, for this opportunity. I really appreciate it. And hopefully we can share some pearls and wisdom from Sydney and Canberra as we go through some cases. So what I thought I'd do is actually go through a number of topics by way of case presentations. And the topics I thought I'd cover would be the following. So murmurs, presentation of murmurs that we see often in clinics, syncope in pediatrics and the sort of red flags, chest pain, pericarditis, and I thought I'd finish with a case called flipped out. All of these slides will be available to you if you chat to Dr. Harcourt and to Dr. Kumar. In terms of murmurs, so this is probably the most common presentation to most, if not all, clinicians at ED presentations post sort of viral induced wheeze treatments and then in subsequent postnatal checks. And in my mind, I always like to explain to parents what's innocent versus what's sinister. And to sort of paint a picture as to what's innocent versus what's sinister is helpful for most parents. And what I describe to them as being sinister and for ourselves is a murmur that sort of is longer in duration. So you hear it at the beginning of the heart sound and it's persistent all throughout the second heart sound. B is a higher intensity, so you can hear it with the stethoscope as it just lightly touches the chest wall. And sometimes you can actually hear it if you're standing away from the child just briefly. C, then obviously, if there's other physical findings, so if you notice labored breathing, tracheal tugging, subcostal recession, or they're quite cachectic. And also, one of the biggest findings is that if you can actually feel the murmur, and by that I mean when you feel the across the chest, if you feel something flicking against your finger, that's often the pulmonary valve or the second heart sound. And that's very specific for certain conditions. And you'll see some tonight whereby if you see it, then your mind must go to, this is actually pathological and this is not something they're going to grow out of. Often the innocent murmurs will change with position, so they're louder when they're supine, um, and often will change. They almost sound whimsical or musical in qualities. So I called this the sort of the mnemonic for innocent murmurs. So similar to myself, somewhat sensitive and short. But the other thing is that they're small and they're soft. So it doesn't sound like it's sandpaper or concrete or anything harsh rubbing against the floor. And most, if not all, of these innocent murmurs will be systolic. So if you're sitting there and you're not sure, how do I tell systole and diastole? You've got a screaming baby, the child's still, losing their mind, they're red in the face, the parents are almost crying, you're almost crying. The easiest way to determine the phase of the cardiac cycle is to actually feel for a pulse. So whether that's the brachial pulse in the infants, a femoral pulse, in the older children, it's a little bit easier to feel the radial pulse peripherally, or the jugular venous pulse. And so if you can time it at the time that the impulse hits your finger, that's the beginning of the systole. And so then if you notice that it goes throughout the entire systolic cycle, then you can say, this is definitely not a diastolic murmur. It's not continuing all throughout. David said to me, if it's short, if it's single, if it sounds almost sweet and doesn't sound harsh, then this is more likely innocent. And that in your mind can be helpful for you. The other thing that I always say is the trend is your friend. If you hear a murmur, and often we receive referrals from clinicians and physicians, and what they're very quick to tell us is weights, heights, and lengths and saturations. And I always say the trend is your friend. If you have a newborn, as I recently inherited a new baby who was 2 months of age, they were born at 3.1 kilos. At 2 months of age, they're now 3.3. That to me screams alarm bells that there's something pathologically wrong. And irrespective of what the murmur sounds like, it's going to be pathological, because in your mind, you should think roughly about a kilo per month of weight gain, so that by 12 months of age, they're roughly between 9 and 11 kilos. So if you remember those numbers, one for every month and 9 to 11 for the year, then if a child's gaining 200 grams every 2 months, you know there's something not quite right. In particular, as the children get older, if they start having dyspnea on exertion, and by this I don't mean that when they're running they stop in the playground. I mean they're completely unable to then walk. They need to be carried. Their parents are having to carry them. And by cyanosis, I don't mean blue lips nor blue hands and feet. I mean blue tongue. So if the comparator is, I'll get the child to stick out their tongue, and if it's nice and pink and the lips are blue, I'm reassured that this is peripheral cyanosis, not central. Central cyanosis, blue tongues, are pathological. And actually, in true honesty, they don't appear blue, but they appear grey, almost similar to the sort of blazer or the jacket that I'm wearing. And in any child that sleeps more than usual, so the parents say, oh, they're a brilliant sleeper, they have 3, 4 naps a day, and then you compare to the sibling who has no naps, then it's got to spark your interest to say there's something not quite right if the older child is sleeping more, except if it's a teenager, in which case then you could probably argue. So what I did is actually divide the congenital conditions based on murmurs into two. Into, could they be acyanotic or not blue and pink, or cyanotic and blue? And by this I mean central, i.e., tongue blue. And for the majority of the acyanotic or the pink murmurs, basically these are the possibilities ahead of you. So it could be a VSD, an ASD, a patent ductus arteriosus, a coarctation. So therefore you feel the femoral pulses and you do some upper limb and lower limb blood pressures. In the older kids, you can do a blood pressure with a normal cuff. In the younger kids, you might have to use the cuff on their thighs, pulmonary stenosis or aortic stenosis. And these, to be completely raw with you, can present at any age. I had a 16-year-old who couldn't feel her toes for a long time, and she had a severe coarctation. By the time she came to me, it was basically the pathway from her aorta to her feet was the width of a hair. And after she had a stent put in, she said to me, for the first time in 16 years, I could feel my toes. So these pathologies can present at any time. So just because it doesn't present when you anticipate it to present, don't dismiss it. The traditional ones that we know about that will present with central cyanosis, blue tongues, desaturation, and these will present varying degrees of in the postnatal period. So transposition of the great arteries, tetralogy of Fallot, truncus arteriosus, anomalous pulmonary venous return. So this will present as a continuous murmur, tricuspid atresia. So where you've got basically underdeveloped left or right side of the heart. These will often present with desaturation and cyanosis. So often the wellness check in the sort of day 3 to day 7 post discharge, I'm always interested to hear what the midwife, the community nurse saw, what they heard, and what they felt, because they have often been able to be the frontline people to pick up on these and often call the GP quickly or the family physician and say, hey, I think I've got a cyanotic congenital heart condition. So what I thought I'd do is, I know it's a little bit tricky because I feel like there's no visual audience that I can see, but I thought I'd go through some cases and break down for you the things that go through my mind when we get phone calls at say 2, 3 in the morning from the fellows or from peripheral hospitals, the things that trigger me to think, is this cardiac, is this not cardiac? So the first case is a 3-month-old that presented with lethargy and feeding difficulties. And often they'll present with sort of snotty nose, runny nose, work of breathing. And you can see on its initial inspection that the vital signs, the oxygen saturation is 98% on room air. The heart rate is 154 beats per minute, but the respiratory rate is almost 80 breaths per minute. So already in my mind, I've got a child that's lethargic, not feeding, and they're acyanotic. So they're not blue, they're pink. So this is going to be down that left-hand column of ASD, VSD, aortic stenosis, PDA coarctation. So what I want to know next from the clinician or the person calling me is, what did they hear and where did they hear it? Listening to the murmur is one thing because that tells you where it's loudest. But where does it go to tells you what is the underlying pathology. So, for example, if it goes to your shoulder, then it's more likely the pulmonary valve. If it goes to your carotids, it's more likely the aortic valve. If it goes to the right of the chest, it's going to be the tricuspid valve. And if it goes to the left of the chest, it's going to be the mitral valve. So wherever the blood flows, and what's really nice about the heart is wherever the blood flows, that's where you can hear the noise, but is at the loudest site that you can hear it. It's almost like putting a Bluetooth speaker in a room. And what my eyes are trying to train me to do with my ears actually is if I close my eyes and I put my stethoscope in that room, I'm trying to listen to see where is that Bluetooth speaker relative to that room. Is where I'm listening to, is that loudest or does it move somewhere? And if it moves somewhere, is that where it's loudest? Because that will tell me what's involved. So you can see they've got a 3-on-6 pansystolic murmur, which we alluded to before, basically goes throughout all of systole, and that the liver is basically 2 centimeters below the costal margin. So this suggests to me that this child's probably in heart failure, feeding difficulties, lethargy, tachypnea with a murmur and an enlarged liver. This is probably going to be something pathological. So, as normally happens, often patients will get an ECG or chest X-ray, and they do the chest X-ray, and this is what they see. So you can see they've strapped down the child because their arms are out of the way. They're probably screaming and hysterical. And you can see the chest wall here. So I refer to chest X-rays as sort of the garage and the cars. And you can see here, this is a fairly big garage, but also a fairly big car. It's almost like a Toyota Prado sitting inside of a huge garage. And you can see that the amount of real estate it takes. You can also see that it looks like it's almost fluffy, like someone's grabbed a cotton ball and sort of dampened it all over the chest X-ray. So this is not clear air spaces. This is actually wet lungs. The other thing you'll notice is that this area represents the right atrium. This area that sits on the diaphragm is the right ventricle, and you can see it's sort of turned up. So this suggests to you that there's whatever the mechanism is for this pathology, is it's causing a dilatation and a volume onto this heart. There's also blunting of this left-sided border. So you can't see the left atrium or the left ventricle on the chest X-ray, but you can see there's something definitely going on because this is starting to be wide. So in terms of, is this chest X-ray, is this wet or is this dry? I would consider this a wet chest X-ray. And you can see that by the sort of tram track lines that you will see in a number of X-rays. So I know people cringe when they look at the ECG, but the ECG, I always say, is going to rule in or rule out things for you. And one of the first things to have a look at is, so I can see there's P waves before every QRS. They're upright in lead 1 and AVF, so I can tell already this is a sinus conducted beat. I can see it's down waves in lead 1 and up in AVF. So this is a right axis deviation, which is normal. But what's abnormal is that I have these sort of elevations in the ST segments, and also I have sad faces in V2, V3, and V4. And these sad faces are actually evidence of strain. So when the R wave and the S wave are so large that they're equal and opposite and almost like hugging each other, then I know there's got to be a defect there. There's got to be a huge hole in there, or there's something that's driving this process. And as such, the volume is bigger, there's more muscle mass. And so this is probably going to turn out to be a VSD. And where the VSD is, it's almost like giving someone the Google map and saying to them, I'm going to tell you the directions to get to Canberra, and I'm going to put some certain landmarks. And by using the sort of words and the key buzzwords of VSDs, then when we're speaking to surgeons and other colleagues, they know where we're referring to. So inlet VSDs at the mouth of or the entry to from the tricuspid valve, the muscular VSDs. So these are the ones that are buried in the muscle wall, the membranous or perimembranous VSDs that you often hear some people say are restricted by tricuspid valve tissue, or they're getting smaller with time, or the outlet VSDs that normally happens where they sort of hide underneath the outflow tract there. So you can see where they are will determine where it's loudest and therefore where the blood flow is going to sound softer as it travels from. And depending on the size, really, of the VSD, will depend on what we do next. So if you had a small mid-muscular VSD, so something in this area, this is actually promising. The further away it is from the valves, the less likely it's going to cause damage to the valve, and as a result, is going to lead to lifelong consequences. When it's buried in muscle, it's more likely that muscle will grow there with feeding, growing, and development, and that it will close spontaneously. The perimembranous VSDs, the tricky thing with them is that the perimembranous VSD will often include the aortic valve. And as it does so, it actually can often distort and or damage the valve. And once there's aortic valve regurgitation, then you know that this has caused absolute distortion for life. And we try to prevent that from happening because once you damage the valves, then that's a huge problem. And so this is sort of an example of one where you can see they've drawn, that's the stay stooges, and that's the VSD there, and they're trying to close it there. The moderate to large VSDs will definitely need closure. And the idea is to protect the lungs, which will develop up until about age 8, and stop the development of pulmonary hypertension or Eisenmenger physiology. And the way we sort of medically manage these whilst we're waiting for surgery include things like the diuretics, optimizing nutrition, nasogastric tube feeds, fortifying feeds. So, if they're breastfed, we'll, give them the breastfeed plus top ups, or we'll add calories to their breast milk or to their formula. And then with the idea that we try to like fatten them up prior to their surgery, because we know in the post-operative course, they're definitely going to lose weight. The other thing to say is that there's now a trend to see where possible to close these VSDs with transcatheter closure, because especially in the Southeast Asian um, continents, and where culturally it's some parents are of the thought that we don't want a median sternotomy. It's quite disfiguring. It's going to affect their life and things like that. Then often they will opt or ask for a transcatheter approach. So the first case that we talked about was the VSD, and I figured from there, it'd be nice to go to the other end of the spectrum. So this
David,
was a
David, is it possible
yes.
to just interrupt? We've got a question from the audience just about
Oh
the
yeah, sure.
VSDs. Can you comment on what the millimeter size makes it a small, moderate, or large VSD?
Yeah, that's an excellent question. So normally, I mean, when we look at sizes, it's a bit tricky because we're measuring a three-dimensional defect. You can imagine if we're measuring this defect here, and I say it's 5 millimeters, then that's a moderate VSD. The issue that happens is that depending on the operator, i.e. myself or someone else who's scanning, we may underappreciate the VSD. So oftentimes that people will ask you to show the VSD from multiple angles. So it's almost like if I give you a bird's eye view of the whole, and then I sort of take one from the side and one from below and one from the other side to show you how its architecture is. And as you can see here, they're not perfect holes as in circular rings like a Cheetos ring or something like that. They often will have some disfigurement to them. And so the manipulation of the VSD and the size will vary based on the imaging. But roughly, ballpark figure, 3 to 5 millimeters is sort of the moderate size. Anything above that is what I consider large. Anything below the sort of 3 millimeters is sort of the small moderate range. Anything below 2 millimeters, then it's too small to be significant.
And just a question from me, how early can you see these on prenatal scans? Can you see them at the 20-week scan or?
It depends because the hemodynamics during the fetal scans, often the right side, the pressures are quite elevated. If they're quite small, and one of the caveats we used to say when we did fetal scans was we can't exclude small or minute holes because you just absolutely can't because the software is not there. So as much as you're zooming up something the size of your thumb, if you miss something small then it's basically a limitation of the software. So in terms of what happens, the postnatal check, the first check, which we used to do as registrars and residents, and if you heard a murmur, you'd escalate it to your consultant, was because that was then clinically significant because that may be something that's missed antenatally because they couldn't see it, and or the pressures were equalized. So therefore, the hole may have been a lot bigger than appreciated on the scans.
Right. Yep. Thanks. Okay. Sorry. Continue to case two.
Okay. So case two. So this is normally what we sort of get. So we get a number of referrals, and we in our mind we're trying to triage it, but it's often not fair to make a decision because, as you'll see, the signs sometimes are just not there. So this is a 4-year-old boy who was referred for a murmur. The family denied any symptoms. And the only comment the mother had said to me was that no matter what he eats, he does not gain weight. He eats what we eat, and he was having steak and beef and chicken and everything, but he just would not grow. So I'm just going to minimize this just so you can see. So he's 4 years old, he's 100 centimeters, and he's 14.8 kilos. So he's sort of small. His blood pressure was completely normal, 100 on 61. His heart rate was 108 beats per minute. His oxygen saturations were normal. His respiratory rate was a sort of the upper limit of normal, but otherwise nothing untoward. And on examining him, all I could hear was a fixed split second heart sound. And I'll show you the significance of this. So when we breathe in and out, the um, the heart sounds will change with respiration. Often the first heart sound, the S1, and the S2 will be at fixed intervals with normal respiration. As you ask them to take deep breaths in and out, there'll be changes between the aortic and pulmonary valve, and so they will start to vary. Now, if you ask the child to take deep breaths in and out, and the murmur sounds exactly the same, no matter how much breathing in and out they do, no matter how much they do in terms of posture, lying or standing, jumping up and down, running up and down the corridor, then that's typical of what you're going to see next. So you can see he had no liver, so he's not in heart failure. And this is his chest x-ray. So this was You can see once again, so this is the garage. You can see he's got a medium-sized car. This is not a Toyota Prado, but maybe something smaller, maybe a Nissan X-Trail or something smaller. But you can see here, there's the right atrial component, there's the right ventricle, and once again, this flattening that you see here, I always say is potentially a pearl that elicits there's something going on. The other thing that you can see, which is quite interesting, is you can see on the dilatation of the end on bronchioles. So it looks like someone's grabbed sort of spray paint and sort of sprayed it all over the chest on this darker field. So I haven't attenuated the opacity of this, but for reasons on this X-ray that it will become quite clear next, this is quite unusual. So sometimes people would say there's tram tracking. So you can see it looks like fingerprints, like someone's grabbed their fingers and plastered them on the chest wall, or you'll see these end-on bronchioles. So this is either post-infectious or post-inflammatory changes and or signs that there's increased plethora in the lungs. So he had an ECG as well, and I've highlighted in the red boxes here some of the things that you'll see on the ECG. So once again, so you can see he's got deep S waves in lead one. He's got what looks like a bunny rabbit ears in AVF, but it's completely sinus. It's a normal rhythm, and so there's right axis deviation at the age of 4. Now, if you see right axis deviation at the age of 4, that's unusual because usually what happens in the first few months of life, you'll have a right axis deviation because the right ventricle is the dominant ventricle in utero. As you get to sort of 3 to 8 months, it'll start to transition and swing from a right axis to a left axis or adult type axis. And so if it's still persistent at age 4, then that gives you a clue that the right side must have more muscle or volume, and that's what's generating that. The other thing that you'll see is he's got Q waves in lead V1. Q waves in children is pathological only when number one, it's in the first lead, or number two, if it's in one AVL, V5, and V6. So if ever you see Q waves in lead one and this sort of unusual appearance of the RSR pattern, so where it looks like bunny ears, as you can see here, or you can see them in lead one, AVL, V5, and V6. That's a pathological Q wave because that's not normal. And so this young boy had a moderate size atrial septal defect. And atrial septal defects are probably one of the most common causes of congenital heart disease and present in about 25% of live births. Now, when I say atrial septal defects, I literally mean the septum is missing. I'm not talking about patent foramen ovales or PFOs because that's actually a normal physiological phenomenon that will often close in the postnatal period. And the most common is actually the ostium secundum or the ASD secundum type, where basically it's a failure of migration of the cells towards each other, and so it stops short. So the superior and inferior are trying to grow towards each other, then they stop. And often the thought is that when you have these defects, what will happen is they will have dyspnea on exertion, they'll have shortness of breath, they won't get it on the flat, so they'll often get it when they're climbing stairs, when they're going up to the second floor of a house, when they're in a long distance marathon with their peers. So when it comes to preschool kids, often they'll just keep running until they run out of energy. And the thought is that if you can close these ASDs by transcatheter approach, that's the most favorable. Now, the caveat to that is that you want them to be as big as possible. So ideally, roughly about 5 years of age or 20 kilos, because the delivery system on which these devices are put on are somewhat bigger. So therefore, the bigger they are going into this, the more likely they will be successful. There has been um, discussions about some of the other defects. So we often will see kids that have sinus venosus defects. So that's where the pulmonary vein enters and it sort of volume loads the right side of the heart. Or you have a primum defect. So this is what you often see in kids with Down syndrome. Or you have a coronary sinus ASD. So basically, the coronary sinus, instead of draining, normally will have a defect there and it causes basically a volume overload. So this defect doesn't cause a pressure overload, it causes a volume load on the right side. And so as it dilates, what causes a fixed splitting is it takes longer for that blood to empty from the heart, and there's something called a almost delayed phenomenon from the right ventricle. And as a result, that's what causes the murmur. So instead of it, filling with 100 mils of blood, fills it with 120 mils. That extra 20 mils takes a little bit longer to squeeze out, and that's what causes the murmur. The hole itself doesn't cause it, but the volume on the right heart causes it. In one of the things that we're trying to prevent is obviously Eisenmenger physiology. In other words, instead of the blood going from the left side to the right, as in with this boy, so that's why his saturations were normal, is if he came in with saturations of 80, then that would be more worrying because that would mean that the blue blood is now going into the left side of the heart, and this would be a contraindication for us to close it. By then, it's too late to close. So before I go on to case three, is there any questions, Dr. Harcourt, that have come up? Or
Uh, Is there anything about, do you cover women on medications in pregnancy that can cause any of these heart defects or SSRIs and pulmonary hypertension? Are they?
Yeah, so that's an excellent question. So there has been some literature to suggest that there are some uh, not causal, but there's associations. So we know that some children have, for example, the SSRIs. There's also postulation that some of the medications used for the hypoglycemic infants. So when instead of the sort of glucagon, when we're having to go beyond that and we're giving medical therapy for that, that can predispose to pulmonary hypertension. There is a case towards the end that you'll see where pulmonary hypertension becomes a flavor for. And actually, I have a patient currently who basically their presentation for their heart failure was pulmonary hypertension. And my anticipation is that this child actually had a significant cardiac shunt for 9 months and then presented sort of a few weeks after in the postnatal period. And so, unrepaired, significant shunts, once that pulmonary vascular resistance drops at about 6 to 8 weeks, is often when you'll see them. So, when you're asking before about sizes of holes, when they come in for their 6 weeks vaccines, that's probably one of the best times to actually do a cardiac exam because often that's when the pressures are nice and low and the shunts will really show themselves. So there is some associations with some medications, but right now there's not a causation, so to speak.
Thanks. Okay, that's it for the questions at the moment. Thank you.
Okay. So case number three. So this was uh, an 8-year-old boy who I was contacted about. It was in that December New Year's period when something is always going wrong during that Christmas New Year's period, and people are out and about and doing activities. And this was an 8-year-old boy who was playing in the pool with his siblings, and he was at one end of the pool, his family was at the other end, and the sort of siblings were in between. And as he walked from one end of the pool to the other, he got a fright. He missed his footing after he got frightened. So he got frightened and was trying to sort of get to the end so he could get out of the pool. This was above ground pool. And then passed out in the pool. And so his sister actually pulled him out of the pool, out of the side of the pool. His father then performed CPR for 3 minutes before there was return of spontaneous circulation. So, like I said, he's 8 years old. He's 25 kilos and never had a problem in his life. Never complained of chest pain, shortness of breath, no palpitations, completely normal cardiac exam with no murmurs. His respiratory exam was completely normal, so he hadn't aspirated, hadn't swallowed any swimming pool water. There was no palpable liver. His pulses were normal, so not a coarctation or something sinister. And the team were very astute in doing all the bloods, and all his bloods were pristine. So his calcium, magnesium, apologies, that's phosphate on the end there, completely normal. He hadn't had a seizure, and so hence they called us to say, could we get a non-urgent echo? And this is his X-ray. So this X-ray was done peripherally, and when I looked at it initially, it was, during that Christmas New Year's period, and I thought, I'm looking at this thinking this is completely normal. So this is a normal cardiac silhouette or normal garage, normal heart size for this individual. The mediastinum is not widened. The right atrium looks a good size. The right ventricle doesn't look dilated. This appears like it's got a normal notching. I can't see any fluid in there. There's no pleural effusions or pericardial effusions. This looks normal to my eyes. So beyond this, they did an ECG, and actually, this young boy was actually saved by the registrar, who flagged to her consultant there was something wrong. So the pearl to this ECG is, if ever something looks like a Nike tick, or if ever it looks like it takes a long time between the R wave and the T wave. So the sort of rough rule of thumb I use is the distance between one spike and the other. The QT interval should be less than 50%. So if you look here, if you count roughly, there's 1, 2, 3, 4 and a bit squares. This takes up more than 2 squares. So that's a bit sinister. And what you'll see here is that there's down an almost equiphasic QRS complex. This is actually downsloping. This is upsloping. So this is a normal QRS axis. But what's interesting is that his QTC, when the machine calculates it, it calculates it as a 473. When you do it manually, it's 492. So this young boy actually had long QT, and his first presentation was an out of hospital cardiac arrest where he passed out in the pool. And so this young boy actually progressed to come down to Sydney, and then had a number of discussions about therapy and treatment, and his family and his siblings were screened. And he was the only one that had an abnormal or pathological ECG. And so when we talk about cardiac syncope, and one of the things that we always flag is anytime a child says there was no warning, so they didn't have spots in their vision or spiders in their vision, didn't have ringing in the ears, they didn't feel like this impending doom about to happen, there's no pins and needles in hands and feet, um, and it happens really quickly, really suddenly, or it's preceded by palpitations and then collapse, or it happens in the middle of exercise. So, not the end of a 10-kilometer run, but in the middle of exercise. So, they're focused, they're locked in, they're running, and then they collapse. Or if there's any family history of sudden death, then that's cardiac syncope till proven otherwise, because there's something not right there. And often, cardiac syncope will not have any warning. So, vasovagal syncope or POTS or any of those, there's often the benefit of having some pre-warning. But if you're passing out as you're walking from one end of the pool to the other because of a fright, then there's something wrong. So I put this in here. This actually comes from the Royal Children's in Melbourne, where they look at how do you treat this. So, if there's cardiac red flags on history, an abnormal exam or an abnormal ECG, you refer to cardiology. So instead of referred for neurology for seizures, you can see this young boy would have been referred straight to cardiology. But not to dismiss the neurology and the seizure response, because what was eventually, in retrospect, evident was that he didn't have any loss of consciousness, or stiffening or incontinence or anything like that. He wasn't febrile, his bloods were pristine, and so it was not seizures. And he wasn't standing in the pool and became dehydrated, and it's not vasovagal. So you can see here, one of the things that, if there's red flags, if the history is suggestive, the exam is abnormal, then you've got to refer to cardiology. So the treatment for long QT, actually, part of it is actually avoiding certain medications. So there's certain antibiotics, so the macrolide antibiotics, in particular erythromycin, some of the antihistamines that are over the counter, are actually avoided. So there's a whole website called Credible Meds, where it flags for you things to avoid. And believe it or not, actually, we give beta blocker therapy, and beta blocker therapy has been shown that once you give it regularly, it can actually shorten the QT interval and protect them. So for the children that are on beta blocker therapy, they are often quite diligent with it. This young boy actually own the responsibility of taking his beta blocker and would get up in the morning and say to his mum, "It's time," and then she would know it's time for him to take his medication. The difficulty becomes that if you've got children that have got bad asthma, and by bad asthma I mean the child that's got ICU admissions or frequent ED admissions, is on a number of preventers and puffers and Singulair or Montelukast, then you got to think about surgical procedures like a sympathectomy to see whether that can ameliorate things. And obviously, the sort of surgical intervention for those that are still at high risk despite optimal therapy would be an ICD or implantable cardioverter defibrillator. This is in kids that have had cardiac arrest and where you can't achieve control. Dr. Harcourt, any questions on case number 3, the long QT?
No, that was very useful though. Thank you.
Okay. So I'm going to go on to case number 4, and hopefully I'm doing okay for time. So this was one of the cases that I was exposed to shortly after becoming cardiology fellow. And the last thing you want at midnight is to be called about a 7-day-old, born at 38 weeks gestation. So they're fresh. They haven't even gone for their 6-week check yet. They're referred to ED with feeding difficulties and weight loss. And they're actually referred by the community nurse who had seen the child and said, "This child latches on, sucks for a few seconds, screams, goes red in the face, and then basically passes out and goes to sleep." And when they were discharged, they were having 60 mils every 3 hours. And now at 7 days of life, they're having 15 mils every 2 hours. Now, often some people, when I put this up, say, "Oh, it's fine, David, they're cluster feeding." But surely if they're cluster feeding, they're not going to cluster feed less volume more frequently. Surely they would cluster the same volume, but just, more frequently. However, when they tested this theory, every time they were giving the 15 mils, he'd have increased worker breathing, he'd become tired, but there was no sweating. And so when you look at the child, and you can see this is literally what it looks like when they come into the emergency department, screaming hysterical. You can see the subcostal recession there. So the child is screaming, losing their mind. You can see that they've got proximal muscle wasting even at 7 days old. So the thigh muscles are not quite thick. So therefore you should be able to feel some femoral pulses. But when you examine the child, the heart rate's 184, the rest rate is 90 breaths per minute, the saturations are completely normal, but your blood pressure doesn't pick up. You put on the automatic cuff, it doesn't read. Error 2. You put it on the feet, error 2. So you go on to examine the child, you think, "I'll give that a break, I'll come back to it." The child's not dysmorphic, but they're grey. And you can see this is what I mean when I say grey. So the bottom half is pink, the top half is grey, there's 2 different colours. And they literally will appear like this. So they're tachypnic with subcostal recession. The hands and feet are cold to touch. So this is ice cold. This feels like a heater. Baby has a weak cry. The radial pulses aren't easy to feel. The brachial pulses are just palpable. And the heart sounds are normal, but you think there might be a murmur, but you try to feel the femorals and you're like, "For the life of me, I can feel nothing." And often, if there's any doubt about the femoral pulses, then you need to suspect that there's got to be something pathological. So you can see that this is the chest X-ray performed. Once again, the lung silhouette or the garage. You can see the heart looks big, even for this garage. So this once again looks like a four-wheel drive sitting in this garage. You can see how the tip of the heart is upturned. So this will often happen when you have the left ventricle dilated. The tip of the heart will go up, almost like a boot-shaped heart. Whereas when the right side is dilated, the tip will go down. So the tip that you see here on the screen will point towards your left hip if the right side is dilated, or it'll tip up when the left side is dilated. And you can see there's obviously some still transient changes from that newborn period, but this lung looks like it's wet. The other thing to say is with for the very astute and that probably saw it, you can often in this condition you'll see something called notching underneath the ribs. And because the nerve artery veins sit on the bottom or the inferior border of the rib from as you recall from anatomy. And so when you get a pinched in appearance or almost looks like a tented appearance, then the anatomy that fits with that is what's going to be revealed shortly. So you do your ECG, and the ECG looks like this. So basically, the sinus conducted beats, but you can see how prominent these forces are. And you can actually see, so if this was an adult, there's ST segment depression in 2, 3, and AVF, and there's ST elevation in V2, V3, V4. So this suggests some sort of myocardial ischemia or injury. And you can see how big the R waves are, how deep the S waves are. There's something abnormally wrong with this muscle and predominantly on the left side of the heart. And so with weak femoral pulses, ischemic changes in the right side, and abnormal elevation on the left side, this is a coarctation. And remember that the coarctation doesn't necessarily have to present on day 0 of life. Often the PDA will take some time to close. We've seen them present at a week of life, at 2 months of life, at 15 years of life. So they can present at any time. And often when the PDA closes, it will pinch in with it some of the aorta. And when it does, you can see the sort of change it does or conical change it does to the aorta. So it almost looks like a wine glass then. And as it pinches in, that area where you're listening will cause the murmur. So when you listen at the front, you'll say there's something unusual. You listen in between the scapula or in between your blades of your shoulder. You'll listen, the same murmur radiates through and through. You've got your diagnosis. So weak femoral pulses, a child that's not feeding with a murmur that goes through and through, has got to be a coarctation to proven otherwise. And you can see that the most important thing is to start frosting so you can open the duct or basically see if we can ameliorate the duct again. And then obviously definitive surgery by uh, a coarctation repair from the side of the thoracotomy, or in the older kids, to put in a stent if it's favorable and away from the head and neck vessels. Any questions about case number 4 before we go on to number 5?
So can I just ask, why would the child not be eating or not feeding?
So what actually happens is you get gut ischemia. And so normally what happens is if you can imagine that you've got poor perfusion to your gut, they have microischemia. And so you will definitely have some runoff of your blood flow, but the blood flow to the gut will be much, much lower than the blood flow to the upper limbs. So they can take it in, they'll be vigorously sucking, but they can't digest it. So the food just sits there. So often they'll appear gray. Some of them actually will feed and then vomit. They'll have effortless vomiting. And
Mm,
so then they won't gain weight. So they'll
mm.
present at the sort of 1 week check or the 4 week check, and they wouldn't have gained weight. And you'll feel for the femorals and you can't feel them. The other thing to say is when you're feeling for hands and feet, most babies, if not all, will feel like they've got freezing hands and feet. But you should be able to feel for the femoral pulses, and it should feel as prominent as it does the brachial pulse. They should be of the same quality and or nature.
Thank you. Thanks.
Oh, you're welcome. So we're almost in the home stretch here. So case number 5. So I put this in because we often get, uh, presentations for chest pain, and often I'm not sure if the chest pain is, gives us chest pain as well because we sit there and wonder and neurose and worry. But this is a 15-year-old athlete. So she had injured her knee during gymnastics and she'd recovered from a viral illness. She presents the emergency department with a 12-hour history of chest pain. Now, the issue is that this is the third time she's presented with chest pain. So she presents the first time, the chest pain disappears, so she goes home. The second time she presented, she waited 6 hours. She was seen by the ED. They said to her, look, we'll send off your bloods, and then you can go home. We'll call you if there's anything abnormal. So she went home. There was no phone call follow-up. So the third presentation, the reason she presented is she couldn't sleep. So whenever a child wakes up or an individual wakes up from sleep with chest pain, then I take it seriously. And three presentations to a physician is always a red flag. There's got to be something pathological or something sinister. So the first episode of chest pain, it started after her meningococcal vaccine. And when she did complain of the chest pain, she said it was 7 out of 10. It was relieved by omeprazole. However, on the morning of the chest pain, she said it was associated with dyspnea in the morning. Occasionally, she gets palpitations, but the pain was relieved by Nurofen and Panadol, which makes the provisional diagnosis of gastroesophageal reflux disease a little bit difficult to sort of absorb because you're now saying that it was relieved by this, but it was also relieved by this. And often, any chest pain that's relieved, I always wonder whether it's because of the fact that we've just turned down the 7 out of 10 pain to a 5 or 4 out of 10 and they've tolerated it. The other thing to say is there was no syncope and she'd returned to playing water polo. So she's got chest pain, three presentations. It's relieved by some over-the-counter products, and at the same time she's back in the swimming pool. So when we examine her, she's got a normal cardiac examination. She's got a pericardial friction rub. She's got normal breath sounds, no palpable liver. Her JVP is not elevated, and there's no edema. So she's not in heart failure. However, she has this ECG. So this ECG you can see is at normal voltages, and you can see the most unusual thing about this. So it's sinus rhythms, so P waves before every QRS, but there's these ST segments that are elevated. They're also elevated in V2, V3, V4, V5, V6. So this is what we call diffuse ST segment elevation. So, and this is very specific for pericarditis. So everything and anything can contribute to pericardial inflammation and or irritation. So the red flags that you want to know about are, could it be pericarditis post-surgery? Because these children will often develop significant pericardial effusions. And if you listen and you can't hear the heart sounds, then you've got to send that child to ED because it's probably a significant pericardial effusion or the heart might be engrossed in pericardial fluid and they might be having tamponade physiology. The other thing that we always worry about is that in a child I've had 3 children that have had small VSDs that have had endocarditis inside of the VSD. It's truly very, very, very unlucky and unlikely, but don't ever dismiss it. So if a child's sick or unwell and they've got fevers and you know they've got a history of having had a VSD, don't ever dismiss it. The other thing to say is connective tissue disorder. So they've got a family history of Marfan syndrome or aortopathies or someone passing away suddenly at the age of 50. Then you always got to think about dissection or rupture of the aortic root and Kawasaki's disease. We probably see more Kawasaki's presentations now because people are more attuned to the symptoms and even the atypical Kawasaki's. So, just because you're Caucasian and older doesn't mean you can't get it. I had a 10-year-old boy who had Kawasaki's with all the classic features. They were advised that it was glandular fever. Then they were told it was EBV. Then they were told it was upper respiratory tract infection. And then they sent the child to me after 21 days. I put the echo probe on his chest. I was like, this is Kawasaki's. There's nothing else in the world that's going to cause this. And his coronary arteries were bright. They were as bright as the writing on this slide. And so he received IVIG even after 21 days and was treated with aspirin and made a remarkable recovery. Any family history of cardiomyopathy or conduction disorders are your red flags. The yellow ones, I always say, so these are the ones that you don't want to dismiss. So whenever I ask about chest pain, I always say, does this pain move to your arm, neck, or jaw? And I'll literally do it in front of them so they know what I'm referring to. Because I want to know whether this same pain is happening at the same time or is it two separate pains? And so when you can elicit the difference between them, then you can start to gain a picture as to, is it red flag territory, is it amber territory, or is this going to be green? And so the amber ones you want to worry about are things like associated with palpitations, associated with syncope, radiation to arms and jaws. The green ones, these are the less likely going to be the pathological chest pains. So this is where everything's been done. The ECG is normal, the cardiac exam is normal, the X-ray is normal. You do a troponin, the troponin's 3. So then you ask them, how often do you get your chest pain? Ever since I asked one girl today, and she was 9 or 10 years of age, she said, ever since we moved from Sweden, where I was born, to Australia, I've been having chest pain. And so she's been having chest pain for 10 months. And I said to her, why do you get your chest pain? She's like, I don't like it. I don't want to move house. I don't have any friends. And so every time I think about it, I get chest pain. So when there's a clear association, then it's always a lot easier not to go down the rabbit hole of thinking, could it be heart, without teasing out which of these traffic light systems it belongs to. Red, I definitely want to escalate. Yellow, I definitely don't want to dismiss. And then the green, okay, I'm safe. We can delve into this a little bit more with time. So any questions on chest pain and pericarditis?
No, thanks.
No, okay. Now the last one, as promised. So this is a 9-year-old boy. This young boy actually presented on the day of my graduation from the college. So I was about to walk out the house, had the suit, everything ready, and I got a phone call to say there was a boy that had an out of hospital cardiac arrest at Flip Out. So the story was that he was about to go down a slide. He'd bumped his head, and as he went to the bottom, he started feeling his heart racing. He got to the bottom of the slide. As he was walking towards his mother to tell her something was wrong, he put out his hand and he collapsed in front of her. Uh, Incidentally, a bystander was by and gave him 4 cycles of chest compressions. An ambulance was called. He started to froth around the mouth. He became more alert. His color returned. His eyes deviated to the side. Uh, the ambulance assessed his GCS and it was 15. They did a blood sugar and they took him to hospital. Now, in the interest of time, he had no family history of cardiac disease, no personal history of seizures. There was no premature deaths or drownings. There was no abnormal ECGs in the family, but it had a 2-year history of chest pain on exertion, dizziness, and palpitations. So being a hospital, everyone gets a full workup. So had his examination, you could see he's well, he's alert, his oxygen saturations are normal, his systolic blood pressure is normal. He has a normal first heart sound and a loud second heart sound. And actually, the person that examined him said to me, I wouldn't mind if you examined him. And when I placed my hand on his chest, I could feel his second heart sound. So he had normal equal air entry bilaterally. So there was vesicular breath sounds. There was no crepitations, no wheeze, and he had no edema. So like I said before, cardiovascular syncope, the red flags, no prodrome. So yes, he hit his head, but not every child that hits their head then passes out. He had palpitations or chest pain. So for 2 years, exercise-induced ischemia or family history. And this was the chest x-ray. So the chest x-ray was performed that day. So you can see here, this is the lung fields. You can see there's something not quite right here. So with all the chest x-rays, I've been showing you flattened areas of the left perihilar area. Whereas this looks like a bump, almost like a speed bump, a speed hump. You can also see there's some fluid in the horizontal fissure here. So with some imagination, there's right atrial enlargement. And you can see this almost looks like a sac. It almost looks like the heart is sitting in some sort of sac of fluid. You can also see what I was referring to when I say tram tracks. So it looks like skeleton fingers or, the bony fingers in the background of this lungs. And you can see how streaky it appears. So here's ECG. So you can see there's P waves before every QRS, but you can see sad faces everywhere. And I call these sad faces. So whenever you see sad faces everywhere, then you've got to start thinking as to why. And one of the things to point out is sad faces in your limb leads or in your second leads, and this evidence of RSR in lead V2, or as you can see, this sort of abnormal notching here and abnormal QRS progression because you've got tall R waves here and you've got deep S waves here. This is suggestive of severe pulmonary arterial hypertension. So this boy ended up actually having a severely dilated right atrium, right ventricle. His pressure was such that it was suprasystemic. He ended up on a lung transplant list and was aggressively treated. And I saw him 3 days ago now, and he is doing amazing. He was the mascot for the Sydney Swans. His pressures have all normalized on his therapy. His ECG is completely changed back to normal, and he's never had another collapse. So when you recognize, when patients say they've had chest pain or they have persistent pain or they can't keep up with their peers or, symptoms that are just not going away, that are not clear, I think we owe it to them to work them up just to make sure there isn't something sinister in the background. And with that, that is, I think, my last case. Is there any
Um,
questions?
That was just fantastic, David, and I'm so glad we're recording this because I'll probably be watching it again myself, and I know maybe the participants, attendees would be as well. If anyone's in the audience who wants a copy of David's slides, which look like a really useful resource, all those red flags and how to differentiate, just let Canal or email CHN events. And I just had a couple of questions. How often do you see rheumatic fever these days? Not that often in Sydney, or?
Not very often, no. We probably, I think last year I've seen it twice, but we don't. And often a lot of the kids that we see with rheumatic fever have come from New Caledonia or somewhere else. But I've not seen a lot of rheumatic fever.
Right. Yeah. And what about I think there's an increasing diagnosis in the primary care community or general practice of EDS, so Ehlers-Danlos syndrome,
Ehlers-Danlos.
and hypermobility. And when do patients with those conditions need echoes?
To be completely honest with you, Dr. Harcourt, I screen a lot of children with Ehlers-Danlos, and actually often uh, of the proportion that come to me with Ehlers-Danlos, there are some that end up with a diagnosis of Marfan's. So I've had some that have been diagnosed with aortic root enlargements, for which we will often use things like candesartan or atacand or irbesartan. And what it does is actually slows down the muscular wall remodeling. So the aorta will grow roughly at about 0.3 centimeters over a 12-month period. Now, if you think of the height, weight, and the body surface area for a young person, an adolescent or the teenager, if I can halve down or halve the rate of growth or the rate of acceleration of that growth to 0.15 centimeter per year, it'll actually minimize or prevent the risk of it rupturing. And so I will see often a lot of patients with Ehlers-Danlos or suspected Ehlers-Danlos or hypermobility because we don't want to miss the vascular type and or the Marfan's. And so if there's aortic root enlargement, I'll actually facilitate and or help in referring them to genetics so that there's no disconnect between sort of the primary care physician saying, well, David, why is the aortic root, Z score +5? Surely this is not normal. And then having a definitive diagnosis because it means a completely different strategy for treatment.
Yep. Yep, that's very useful. So if there are any questions from the audience, I'll just leave it and see if anybody's got any further questions. And in the meantime, I'll just let people know that they are very welcome to report 1.5 hours of educational activities to their CPD home. And that was such a good and useful and practical presentation tonight. Spot on. Thank you very much, David. And David works in Sydney. I'll let him do a little plug for where he works. So, so
um, yeah. Oh, actually, was there a question there, Dr. Harcourt,
I think we
or did
answered
someone
that
raise their
question
hand?
earlier. No, I think everyone's saying thank you and doing thumbs up
Oh,
and
no,
appreciate.
you're more than welcome. So
Yeah.
I do a lot of, so you can see my plug for my clinic. This is my clinic here in Cogger in Sydney. But otherwise, I do everywhere from Blue Mountains, Warunga, I used to do Dubbo and Orange for outreach for the hospital, but that's currently sort of been transitioned to some other people. And both Westmead and Randwick hospitals, St. George private, St. George public. So I cover about 6 hospitals and 6 clinics. So
Wow.
I try to disperse myself as much as I
Yep.
can. But the education is the best part because then it becomes, if I can show people what we look for, and like I said, the trend is your friend. Often GPs will say to me, I've examined them 2, 3 times and I've seen this persistently, then I trust it because you see them more often than I do. So
Mm,
sometimes I've had patients come to me and say, and I've said to them, look, I strongly recommend we should do surgery for this VSD, and they were not happy with that advice. So I will, before we recommend any particular surgical intervention, I will take that case, present it to a whole group of cardiologists and surgeons. So it's not just on my thoughts, but on the greater good of the group. And if the group agree, then I often will present that back to the family and say, these are the options. This is what we can do. What would you like to do next? And for some families, unfortunately, doing that has scared them away. And so they've just said, well, I don't want to do that. Or they've
mm,
disappeared or they disengage. So it's always hard to, you know, having an answer, oh, you're going to have surgery is not often what parents are looking for. There's often a fear factor of, well, my uncle had that and they died, and my great grandfather had that and he died. So, there's trust that needs to be built, and so that's why I'm dependent on GPs. My father's a GP, so I depend on GPs and clinicians to work together when it comes to these because they're basically the eyes and ears for the patients. And often
yeah.
they won't come back to me first. They'll go back to the GP and said, "Well, David said X, Y, Z. I'm not doing it."
Yeah,
And so
that's
the
a
GP will say, "David, how do we work through this?" So I often say it takes a village. It's not one person running the show.
yeah. Yeah, a lot of the cases you presented were very relatable to primary care. So I think they were spot on. And I just let people know. So David works with Dr. Stephen Cooper, who runs the outreach program from Sydney, and he comes to visit Canberra Hospital or Canberra Health Services, and he kindly volunteered David, and we were very lucky that he did. Anyway, that's it for tonight. Thank you so much again, David. And our next webinar is on the 24th of September, and that'll cover adult cardiac arrhythmias with Dr. Mohammed Paymard. And we hope that you all can make that one, and have a good night. Thank you very much, everyone. Night. See ya.
Yeah, have a good night.